Let us start the anatomy of the basis cranii interna. Here is the what is called as the calvaria, the skull walls. Here is the external and internal occipital protuberance. Here is the frontal crest. Here is the inner table. And this has formed that internal occipital protuberance. So taken off the upper part of the skull and you are looking inside the skull, which is the basis cranii interna. Now there is a free edge of the lesser wing of sphenoid, the anterior clinoid process, two like this, and the other side free edge. Same way there is a edge of the petrous temporal bone, the posterior clinoid processes like this, and the petrous temporal free edge of the petrous temporal bone of this side. And this converts this inner space of the cranium into an anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. Now, just under the frontal crest, you have a foramen which is called as foramen cecum. So, frontal crest, and then same thing, foramen cecum. Behind this you have what is called as the crista galli, where is attached the falx cerebri. Around this you have a plate which has got multiple holes, and this is the cribriform plate of the ethmoid bone. On the two sides you have the roof of the orbit, which is a part of the frontal bone, except in the posterior part. This is the lesser wing of sphenoid. Here you have what is called as the jugum sphenoidale, the peak of the sphenoid, lesser wing of the sphenoid. So this part here, this one, where we are drawing a H-shaped impression, is the orbital plate of the frontal bone. And if you see here, this edge here, you find that the ethmoid has got a cribriform plate, has got, below is the nose, above is the anterocranial fossa, here is the crista galli, and here is the ethmoidal contribution to the nasal septum. Then there are two boxes on each side. These boxes divide the orbit and the nose, orbit here and nose here. And this is the frontal orbital plate of the frontal bone, and between the ethmoid and the orbital plate you have a nerve here which is the nasociliary, nerve, which is in the orbit. It passes through these foramen, which are called as the ethmoidal foramen. There are two of them, the posterior one and the anterior one. So the anterior and posterior ethmoidal nerve pass through this into the anterior cranial fossa and enter the nose through the cribriform plate. So here you also have the anterior and posterior ethmoidal foramen. And this H-shaped fissure on the orbital plate of the frontal bone is because of the impression of the frontal cortex, impression of the gyri and sulci of the frontal cortex of the brain. Then below this, you have the jugum sphenoidale here. And behind this you have this prominence, which is called as the tuberculum celli. So here is the tuberculum celli. On these two sides are the anterior clinoid processes. Then you have a foramen on this side of the clinoid process. Let us make this foramen blue. A foramen here, which is the optic foramen, and on the lateral side of the clinoid process you have another foramen, which is the superior orbital fissure. So we'll put these names also. Keep on putting these names. Optic foramen, which passes the optic nerve, and the superior orbital fissure, which passes the third, the fourth, the fifth A and the sixth nerves, cranial nerves, the superior and inferior ophthalmic veins, and lacrimal branch of meningeal and meningeal branch of lacrimal artery. So the superior orbital fissure passes the, you can remember, third, fourth, fifth, sixth nerve, superior and inferior ophthalmic veins, the lacrimal branch of meningeal and meningeal branch of lacrimal artery. You'll have to remember it this way. The optic foramen passes the optic nerve, and the cribriform plate that we see here of the ethmoid passes the anterior and posterior ethmoidal nerves, branches of nasociliary as you have seen, and the olfactory nerves, 20 on each side. Thus we finish the anterior cranial fossa. Now we'll draw the diagram again. And we'll now concentrate on the middle cranial fossa. So foramen cecum, crista galli, ethmoidal plate, lesser wing of sphenoid, jugum sphenoidale, optic foramen, superiorbital fissure. This much we have covered. Anterior and posterior ethmoidal foramen, H-shaped impression for the frontal cortex. This much we have covered. And now the middle part of the middle part. This middle part is called as sella turcica. So if you see it from the side, there is this jugum sphenoidale, then there is the tuberculum celli, then there is sella turcica, and then there is something which is called as dorsum celli. In this will lie the pituitary gland, and on the roof of it you have the what is called as the diaphragma celli, through which the hypophysis cerebri or the infundibulum of the pituitary gland, and the pituitary gland lies here. So this is called as tuberculum celli. This one, tuberculum celli, sella turcica, and dorsum celli. And the above part is called as diaphragma celli. Okay, so this is tuberculum celli. These are the two optic foramens. This is the anterior clinoid process, the posterior clinoid process. In the anterior and posterior clinoid process, connecting them is a membrane like this, and in this membrane is the hole through which the infundibulum of the pituitary fossa passes. So this membrane is called as diaphragma celli. Okay. On each side of this hypophysis cerebri, if you see it from this side, anterior view, you will find that on each side of this here is your diaphragma celli, and here is the pituitary gland. On each side of this bone, which forms the sinus, which is the body of the sphenoid and forms the sphenoidal sinus, you have the cavernous sinus. So you have the cavernous sinus here. And in the cavernous sinus, there lies the internal carotid artery. Just near the internal carotid artery lies the sixth nerve. And on the side are four nerves, which we will call O-tom. So O-tom on the side, let us name them. O for oculomotor, trochlear, ophthalmic, maxillary. So then the sixth nerve just on side of the carotid artery is abducent, or the sixth nerve. This is fifth nerve. And this, the oculomotor, is third, and this is the fourth. So O-tom, internal carotid artery, and sixth nerve. O-tom, this one is O-tom. Then this one is the sixth nerve, and this is the internal carotid artery. These are the structures that lie in the cavernous sinus. The applied anatomy is that if there is the carotid artery ruptures into the cavernous sinus, the cavernous sinus gives superior and inferior ophthalmic veins into the orbit. Therefore, the pulsations of the internal carotid artery can be seen in the eye, and that is called as pulsating exophthalmos. Another sign would be that if you put the stethoscope on the eye, you may be able to hear a bruit because of the arteriovenous fistula. Artery is internal carotid, vein is cavernous sinus. So bruit and pulsating of exophthalmos in what is called as the carotico-cavernous fistula. Okay. Now, we have already covered the superior orbital fissure. We have already covered the superior orbital fissure by saying that it passes the third, fourth, fifth A, sixth nerve, superior, inferior ophthalmic veins, and lacrimal branch of meningeal and meningeal branch of lacrimal arteries. So we covered the superior orbital fissure. Then the next foramen that you see here is the foramen rotundum. Which passes the maxillary nerve, or the fifth B. Then you see the another foramen here, which is called as foramen ovale. And what passes through foramen ovale? Male passes through foramen ovale. We'll name the male here the mandibular nerve. The accessory meningeal artery, the lesser superficial petrosal nerve, which supplies the parotid, and an emissary vein. Then you have another foramen, which is foramen spinosum. So this is ovale. Then you have spinosum. The middle meningeal artery enters through the foramen spinosum, and you must remember that this middle meningeal artery has a course like this and like this. It's extradural, therefore it's responsible for extradural hematoma and head injury. and this point where you can access it is called as pterion. So you go through the pterion and you can access the middle meningeal artery, and then you evacuate the extradural hematoma and you put a plug in the foramen spinosum so that the middle meningeal artery is blocked. So that is the applied importance of foramen spinosum. Then you have another foramen here, which is called as foramen lacerum. Now this foramen lacerum passes the internal carotid artery, and the course of the internal carotid artery is that it enters through this foramen. It enters the carotid canal from below, passes through the petrous temporal bone here, enters the foramen lacerum and makes a F type of course in the cavernous sinus, and here it becomes the anterior cerebral artery and the middle cerebral artery. So it enters through the internal carotid canal, passes horizontally through the petrous temporal bone, enters through foramen lacerum, lies in the cavernous sinus, making a F type of course, divides into the anterior cerebral and the middle cerebral. Anterior cerebral goes between the two hemispheres, and middle cerebral between the frontal and the temporal cortex in the lateral sulcus. So this is the course of the internal carotid artery, and that's the importance of foramen lacerum. Now, very important, I'll make it much larger and here so that you can remember this. This is the posterior clinoid process. Okay. This is the petrous temporal bone. Here we have a ligament which is called as the petrosphenoid ligament of Guber. And here you can understand what be the cavernous sinus here, seen from behind. So the inferior petrosal sinus passes through this gap and opens in the petros into the cavernous sinus. So this is the inferior petrosal sinus. And in this anterior petrosal sinus, the sixth nerve arises from the anterior surface of the pons, enters this inferior petrosal sinus and passes into the cavernous sinus with it. So this nerve lying in this inferior petrosal sinus is called as canal of Dorella, and this bend is called as bend of Wolf, and this ligament is called as petrosphenoid ligament of Guber. So when the hind brain, there is a membrane which is attached on this petrous temporal bone, and it has got a big notch here like this, and all this is membrane. So if there is this membrane is called as stentorium cerebri. So when there is a intracranial space occupying lesion above the membrane, this whole membrane pushes the hindbrain down, and this nerve, abducent nerve, as the pons goes down, is stretched at this bend of Wolf, and there is a paralysis of the sixth nerve, which indicates that there is a supratentorial space occupying lesion, maybe a hemorrhage. And sixth nerve supplies the lateral rectus. The muscles are supplied LR6, SO4, rest whole thrice. So lateral rectus sixth, superior oblique fourth, and the rest by third. So the lateral rectus gets paralyzed, and that's a sign of intracranial supratentorial space occupying lesion. Intracranial supratentorial space occupying lesion involves the sixth nerve at bend of Wolf, causing paralysis of lateral rectus. And if the patient is unconscious, if you make the head move like a doll, say no, then you can detect this paralysis of lateral rectus, and that physical sign is called as doll eye movement. Okay. So this much here. Now we draw this again, this area, the petrous temporal, the posterior clinoid process, like this. And on this side we draw an impression which is called as the trigeminal impression. Where lies the trigeminal ganglion? On this trigeminal impression there are two hiatus. Hiatus for the greater and lesser superficial petrosal nerves. The greater superficial petrosal supplies the lacrimal gland, and lesser superficial petrosal supplies the parotid gland. The greater superficial petrosal goes through the foramen lacerum, and the lesser superficial petrosal goes through the foramen ovale. We'll cover these greater and lesser superficial petrosal nerves in detail some other time. But when you are doing a trigeminal neurectomy, or you are putting injection in the trigeminal ganglion, then these two nerves can get involved, and there can be a paralysis of lacrimal and parotid gland. So finish the middle cranial fossa, we'll finish the posterior cranial fossa sometime else. Now we move on to the posterior cranial fossa, but before that we must finish off. Here is the cranium, here is the internal crest, the internal occipital protuberance, the free edge of the lesser omentum and the anterior process, the petrous temporal bone, posterior clinoid process, and we had covered for you the superior orbital fissure, the optic foramen, the foramen rotundum of the maxillary nerve, the foramen ovale, the foramen spinosum, the foramen lacerum, the impression of the trigeminal nerve, where there is the hiatus of the lesser and greater superficial petrosal nerves. So, the hiatus of the lesser and greater superficial petrosal nerves. The last part of the middle cranial fossa is the tegment tympani, which is this area. And this tegment tympani overlies the mastoid antrum, which gets filled with pus. It gets filled with pus in chronic suppurative otitis media. So from this middle ear, there is a gap, like this, opening into the mastoid antrum. Here is the mastoid antrum air cells, and this gap is bounded by this membrane, which is this bone piece, which is called as tegment tympani. So if there is a pus here, pus from chronic suppurative otitis media filled in mastoid antrum, it can be evacuated through a triangle on the lateral side of this mastoid antrum, which is called as suprameatal triangle of McEwan. Suprameatal triangle of McEwan. But this pus can also sort of pierce, and here is lying the temporal lobe of the brain, so it can form a abscess, temporal lobe abscess, by piercing this tegment tympani. So this is the importance of this tegment tympani, which is the last part of the middle cranial fossa, which we have studied. We have studied in the center of the middle cranial fossa the jugum sphenoidale, the tuberculum sali, the sala turcica, the dorsum sali. He has studied the diaphragma sali, the cavernous sinus on the two sides, then the superior-orbital fissure, the foramen rotundum, the foramen ovale, the foramen spinosum. Then we have studied the foramen lacerum, the internal carotid artery entering through this foramen lacerum like this and making a F type of course. And here it is traveling in the petrous temporal bone, and here is the internal, here it is entering through the internal carotid foramen. Now here, if this petrous temporal bone is involved in osteomyelitis, then this artery will pulsate into the middle cranial fossa. So petrous osteomyelitis can lead to this problem of the carotid canal being directly in contact with the temporal area where the temporal lobe is. So this finishes off the middle cranial fossa, and now we'll deal with the posterior cranial fossa. So the posterior cranial fossa, in the center is the foramen magnum like this, and on the two sides are the femur occipital condyles. Anterior and posterior to the posterior occipital condyles, these are occipital condyles, are the anterior and posterior hypoglossal canal. The 12th nerve passes through the posterior hypoglossal canal. Okay. Then here is the internal occipital protuberance, and here is then impression of. Here is the jugular foramen. This jugular foramen passes here there is a confluence of sinuses. The superior sagittal sinus, the greater cerebral vein of Galen coming from the inferior sagittal sinus. It drains into the transverse sinus. So this is the transverse sinus, which goes into the sigmoid sinus like this and becomes the internal jugular vein. So this is the superior sagittal, the inferior sagittal sinus connecting is the great cerebral vein of Galen. Then the transverse sinus, the sigmoid sinus, and the internal jugular vein. This is connected by the superior petrosal sinus and the inferior petrosal sinus to the cavernous sinus, which is lying in the middle cranial fossa. And this inferior petrosal sinus is passing under the petrosphenoid ligament of Guber. Petrous temporal bone, notch, posterior clinoid process, petrosphenoid ligament of Guber. The inferior petrosal sinus lying like this and passing into the cavernous sinus, and the abducent nerve lying in the sinus and bending around this, which is called as the bend of Wolf, which we have already explained. So the nerve lies in this sinus, and this is called as canal of Dorella, bend of Wolf, passing under the petrosphenoid ligament of Guber. So between the inferior petrosal sinus, which is here, and the jugular vein, beginning of the jugular vein, which is here, there are 3 nerves in the internal jugular foramen, 1, 2 and 3, and these 3 nerves are the 9th, the 10th, the 11th. Then you have the internal acoustic meatus on the petrous temporal bone, and so the 12th nerve, the hypoglossal canal, the 9th, 10th and 11th through this, the 7th and the 8th, the 7th nerve and the 8th, the facial and the vestibulocochlear, through the internal acoustic meatus. All right. And this finishes the posterior cranial fossa.